Imagine the delivery room. You know, you've been anticipating this exact moment for months.
Right. It's supposed to be the best day of your life.
Exactly. You are finally handed your newborn baby. They are beautiful, but then within hours, or sometimes literally minutes, something shifts.
Yeah, the tone completely changes in the room.
It does. The baby goes completely limp in your arms. The breathing becomes erratic, just pausing for these terrifyingly long seconds.
And the doctors are baffled. They whisk your child away to the neonatal intensive care unit.
Yeah, the alarms are blaring everywhere, and suddenly that joyous future you pictured is replaced by sheer, unadulterated panic.
It is a profound, profound trauma.
And for decades, families in this exact scenario were eventually sent home with, vague misdiagnoses, things like cerebral palsy of unknown origin.
Or they were just told their child had a syndrome without a name, just totally in the dark.
Right. It wasn't until October 2014 that two independent teams of scientists finally found the culprit for this specific presentation. It was a single microscopic typo in an uninterrupted sentence of human DNA.
And the shift from that terrifying unknown to a definitive diagnosis, I mean, it's one of the most significant moments in a parent's life.
Absolutely.
But as we know, getting that diagnosis doesn't instantly solve the problem.
No, not at all.
It just gives the mountain you have to climb a name, and that name is PURA syndrome.
Welcome to this deep dive. If you are listening to this, you are likely a parent, a carer, or a family member navigating a PURA syndrome diagnosis.
We are speaking directly to you today.
We are. We know that the very moment you got that genetic report, your entire world changed. Suddenly, you were handed this massive stack of referrals to specialists whose titles you could barely even pronounce.
Overnight, without applying for the job, you basically became the CEO of the most complex, high-stakes medical startup imaginable.
That's exactly what it feels like. Your contacts list is just overflowing, and it is exhausting trying to keep track of who does what.
The burden of that medical management is just astronomical. You're trying to coordinate a geneticist, a pediatric neurologist, an epileptologist.
An orthopedist, a gastroenterologist.
Yeah, and a whole team of therapists.
Yeah.
It feels incredibly fragmented because modern medicine is deeply siloed.
But your child's body is not siloed. It is one interconnected system.
Exactly.
And that is the core of our mission today. We are calling this deep dive Building Your Medical A-Team.
It's such a crucial concept.
We want to map out exactly who these people are, but more importantly, we are going to explain why they are sitting at your boardroom table.
Right, the underlying reasons.
By understanding the actual biology of PURA syndrome, you can organize your contacts, anticipate the challenges, and truly step into that CEO role with absolute confidence.
To build this roadmap, we've synthesized a massive stack of clinical sources for you.
We really dug in.
We did. We're pulling from comprehensive clinical guides on 5Q31.3 related neurodevelopmental disorders, recent medical journal case studies spanning from 2024 through the beginning of 2026.
Plus, vital updates from the Global PURA Syndrome Foundation.
Yes, and the highly specific orphan anesthesia guidelines, along with cutting-edge research coming out of the preclinical pipelines at the Florey Institute in Australia and the Jackson Laboratory.
Okay, let's unpack this. We're starting at the very foundation.
The ground floor.
Right. If you are the CEO of a construction company, right, and you're tasked with fixing a massive skyscraper, the very first person you need to talk to isn't the plumber or the electrician.
No, they just lay the wires.
You need to talk to the forensic architect who can show you the original blueprint and point out exactly where the structural flaw is.
And in your medical A-team, that architect is the geneticist.
The geneticist is where the diagnostic odyssey usually ends and where the targeted management finally begins.
Yeah. And as you mentioned, the blueprint for PURA syndrome was only identified in late 2014.
It's so recent.
It really is. Two independent teams, one led by Dr. David Hunt in the UK and another by Dr. Seema Lalani in the US, published these landmark papers characterizing this condition.
And to understand what they actually found, we have to look closely at how human blueprints are stored.
Right. So inside almost every cell in the human body, we have 46 chromosomes, arranged in 23 pairs.
But these are basically the filing cabinets of our DNA.
Exactly. And PURA syndrome occurs due to an issue on chromosome 5. The medical literature points to a highly specific coordinate, the 5q31.3 locus.
Think of 5q31.3 as the exact street address on chromosome 5 where the PURA gene resides.
Yeah, that's a great way to put it. Now, the PURA gene itself is structurally fascinating. It is what we call a single exon gene.
Which sounds very technical.
It does, but to understand why that matters, you just have to know how normal genes work. Most genes are broken up into coding regions called exons,
Okay.
and these are separated by long stretches of non-coding DNA called introns.
So it's kind of like reading a long magazine article, but the article is constantly interrupted by full-page advertisements.
Yes.
The cell has to physically splice the article together, skip over the ads, to read the actual instructions.
That is a perfect way to visualize it. The cell's machinery just edits out the introns, but the PURA gene has no introns.
None at all.
None. It is one continuous, uninterrupted sequence of instructions. It is highly conserved, meaning evolution hasn't changed it much over millions of years because it is so fundamentally essential to life.
But wait, if it's one continuous sentence with no breaks and no alternative ways to splice it together, that sounds incredibly fragile.
It is extremely fragile.
If there is a typo in that single sentence, the cell doesn't have a backup plan. The consequences must be immediate and severe.
The structural rarity of a single exon gene underscores exactly why the sequence integrity is so critical. This uninterrupted gene provides the instructions for manufacturing a protein called pure alpha. Right, it's a multifunctional protein made up of exactly 322 amino acids. And its defining architectural feature is that it contains 3 highly specific sequences known as CUR repeats.
Repeat I, repeat 2, and repeat 3.
Exactly.
And what is the biological function of those repeats? Like, what is the pure alpha protein actually doing in the body with these tools?
It acts as a transcriptional activator, meaning it binds to DNA and turns other genes on and off,
Okay, a master switch.
basically. But even more crucially for neurodevelopment, it binds to mRNA. Those are the messenger molecules that carry instructions from the DNA out into the cell.
Right.
In the brain, pure alpha grabs onto these messenger molecules and physically transports them out of the neuron's nucleus. It travels all the way down the long branches of the brain cells called dendrites,
Delivering the mail.
delivering the mail right to the synaptic junction so that local proteins can be built. This localized protein synthesis is literally how our brains form memories, learn skills, and build synaptic connections.
Wow. So if we go back to our skyscraper analogy, the PURA gene is the master blueprint.
Yep.
And the pure alpha protein is the site manager running around the skyscraper, taking specific instructions from the central office and delivering them to the electricians and plumbers on the 50th floor so they know exactly where to put the wiring.
Exactly. And if that site manager is missing or can't read the instructions, the brain's wiring is going to be completely chaotic.
The wiring simply cannot organize itself, and the mechanism that causes this chaos in PURA syndrome is called haploinsufficiency.
Haploinsufficiency, yeah. Every person inherits 2 copies of the PURA gene, right? One from each parent.
Right.
In a child with PURA syndrome, one of those copies is perfectly fine. It's doing its job, producing healthy pure alpha protein.
But the other copy has a pathogenic variant, a mutation.
Right, meaning the body's only producing 50% of the normal amount of this crucial site manager.
And 50% is simply not enough to build a human brain.
No, it's not. One functional copy is insufficient, hence haploinsufficiency.
This brings up the most agonizing question parents ask when they are sitting in that geneticist's office staring at this blueprint.
I know exactly what you're going to say.
If my child has a broken gene, did I give it to them? Is this my fault? Are my other children going to have this?
The geneticist's most important immediate role is to lift that immense burden of guilt right off the parent's shoulders.
It's such a heavy burden.
It really is. But in the vast majority of cases, PURA syndrome is not inherited. It's not something the parent carried or passed down. The mutations are primarily what we call de novo.
De novo, meaning from new. It happens spontaneously.
Exactly. It occurs spontaneously during gametogenesis,
Which is?
the creation of the specific egg or sperm cell. Or it happens during the very first cell divisions of the embryo. The parent's blood will be tested and they will not carry the mutation.
So they are completely clear.
Yes. Because it is a completely spontaneous biological accident, the recurrence risk, meaning the chance of having another child with PURA syndrome, is incredibly low. It's typically calculated at under 1%.
Hold on, though. If it's a completely spontaneous event that the parents don't carry, why isn't the risk 0? Where does that 1% come from?
Right, that's a good question. It accounts for a very rare biological phenomenon called gonadal mosaicism.
Gonadal mosaicism.
Yes. This happens when a tiny cluster of cells, exclusively in a parent's ovaries or testes, carries the mutation. Even though the rest of the parent's entire body, including the blood drawn for their genetic test, is completely clear.
Oh, wow.
It's rare, But it's the reason a genetic counselor will never say the risk is absolute zero.
Let's talk about the specific typos on this blueprint. The literature lists all these different types of mutations, missense, nonsense, frame shifts.
Like a lot of jargon.
For a parent reading their child's genetic report, these words are just intimidating. Can we break down what these actually mean for the pure alpha protein?
We can group them by how they damage the protein. Let's start with a nonsense mutation.
Okay.
This is a typo in the DNA that creates a premature stop signal. It literally tells the cellular machinery to stop building the protein halfway through.
So it just gives up.
Yeah. The result is a truncated, useless fragment of a protein that the body usually just destroys.
Got.
Then you have a frame shift mutation. This happens when a single letter of DNA is inserted or deleted. Because DNA is read in blocks of 3 letters, shifting the entire frame by 1 letter means every single word read after that point is total gibberish.
The resulting protein is completely unrecognizable.
Completely.
Okay, so nonsense is carrying the blueprint in half, and a frame shift is reading the blueprint shifted over by 1 inch, so every subsequent measurement is disastrously wrong.
That's a great visual.
What about a missense mutation?
A missense mutation is perhaps the most deceptive. The protein is actually built to its full length, but a single typo causes one amino acid to be swapped for a different one.
It's like substituting a wooden support beam for a steel one in our skyscraper.
Exactly. The building looks complete from the outside, but the structural integrity is totally compromised.
And the sources point to a very specific common missense mutation, a mutational hotspot globally. It's listed as the P-phenyl33-3-del variant.
Yes. Let's decode that alphanumeric strain, because a lot of parents see that. It means that at the 233rd position in that chain of 322 amino acids, a single amino acid called phenylalanine, abbreviated as PHO, was deleted.
Just one missing brick.
Just one. But molecular modeling has shown us exactly why this is so catastrophic. Missing that one specific amino acid physically distorts the third per repeat we talked about earlier.
It breaks the tool.
It collapses a microscopic structure called the beta sheet. Because the shape of the protein is altered, it physically cannot bind to nucleic acids anymore. The site manager has essentially lost their hands. They can't pick up the instructions.
It is truly staggering to think about. One missing amino acid out of 322 alters the entire trajectory of a human life.
It is staggering.
Now, if this is primarily a spontaneous mutation and the symptoms in the delivery room are so violently obvious, why did it take until 2014 for the medical world to identify this?
Right.
And furthermore, if the geneticist just tells you the typo, why keep them on your A-team as your child grows?
Well, the answer to the first question is purely technological. Before 2014, we simply didn't have the magnifying glass required to read the entire blueprint.
We were looking at it from too far away.
Exactly. We relied on older technologies like microarrays, which could only see huge chunks of missing chromosomes. Finding a single missing phenylalanine was just impossible. The breakthrough came with WES, whole exome sequencing, and WGS, whole genome sequencing.
Let's clarify the difference between those two, because parents will likely see both terms on their insurance forms.
Okay, so the genome is your entire DNA sequence, all 3 billion letters.
A whole library.
The whole library. But only about 1% of that DNA actually codes for proteins. That 1% is called the exome. Whole exome sequencing, or WES, is a targeted test that only reads that 1%.
Because it's cheaper and faster.
Yes, and it became widely available around 2013 and 2014. Suddenly, geneticists could read the exact coding sequences of these children, and that's when they spotted the PURA typos.
So the technology finally caught up to the disease. But again, once you have the WES results, why does the CEO need to keep consulting the forensic architect?
Because the specific type of mutation matters deeply for predicting the child's future. And what's fascinating here is that our understanding of these mutations is evolving literally month by month.
It's not static?
Not at all. The geneticist isn't just a diagnostician, they are your intelligence officer. For example, some children don't just have a point mutation within the PURA gene. They have a larger 5q31.3 microdeletion.
Meaning?
This means the entire PURA gene was deleted, along with neighboring genes like NRG2.
So a whole city block was wiped off the map, not just one building.
Precisely. And clinical studies clearly show that children with these larger microdeletions often have a more severe clinical presentation. They might have more congenital heart malformations or more profound respiratory failure because of the synergistic effect of losing multiple genes at once.
The geneticist tells the rest of the A-team what level of severity to brace for. And the science is moving incredibly fast. Looking at the recent literature, there was a fascinating paper published in 2024 in Neurology Genetics that completely challenged the idea that this is always spontaneous and always severe.
Oh, that case study was a massive paradigm shift. Researchers identified a milder inherited variant of PURA syndrome.
Wow.
They found a mother who had impaired speech and mild learning difficulties, but she was functional enough to go completely undiagnosed for decades. She passed the variant to her daughter, who presented with more noticeable developmental delays.
This was the first time a mild or undetected inherited presentation was documented.
Yeah, it tells us the spectrum of this disease is far wider than we initially thought. You keep the geneticist on your team because they monitor these global databases. They're the ones who can tell you, here's what the scientific community learned yesterday about your child's specific blueprint.
That perfectly sets the stage. The geneticist gives us the blueprint. But for almost every family dealing with PURA syndrome, long before the geneticist sequenced the DNA, there was an immediate, terrifying crisis on the day the child was born.
The initial emergency.
Right. As the CEO, your very first crisis management team wasn't geneticists. It was the neonatologists. The brainstem blueprint was flawed, and the consequences were immediate.
The clinical manifestations of PURA syndrome do not wait. They are typically present from the very moment of birth. The genetic changes we just discussed manifest as an acute medical emergency, which is why the Neonatal Intensive Care Unit, the NICU, is the first battleground.
The clinical guidelines from the sources are very clear about what this looks like. They describe a neonatal triad of symptoms, 3 massive red flags that pop up almost immediately. Let's break those down, starting with severe hypotonia.
Hypotonia is low muscle tone. It's often colloquially described by doctors as floppy baby syndrome.
Floppy baby.
It is a nearly universal feature of PURA syndrome, affecting over 95% of infants. But we have to make a vital clinical distinction here between muscle weakness and muscle tone.
Right, because they're not the same thing.
No, they're not.
It's like, if I go to the gym and lift weights until I can't lift anymore, my muscles are weak, but my tone is still there.
Exactly. Tone is the baseline, continuous electrical resistance in a muscle when it is completely at rest. It's the subconscious tension that keeps your jaw closed and your head upright against gravity.
Even when you're sleeping.
Yeah. A baby with severe hypotonia lacks that baseline tension. They feel literally like a rag doll when you lift them. They slip right through your hands if you pick them up under their arms. They can't maintain their posture, and their limbs just fall completely flat against the mattress.
The second part of the triad is respiratory insufficiency, which, as we established in the introduction, is arguably the most terrifying thing a new parent can witness.
It is the most critical, immediate threat to the infant's life. More than 50% of these infants experience recurrent apneas.
Prolonged pauses in breathing.
Yes. And the medical team has to quickly distinguish between 2 types of apnea, obstructive and central. They require completely different management strategies.
Let's map that out. Obstructive apnea sounds like a mechanical blockage.
It is. Obstructive apnea happens because the muscles of the upper airway, the throat, the soft palate, the tongue, they're so incredibly floppy due to that hypotonia that they simply collapse inward when the baby tries to inhale.
Physically blocking the airway.
Yes.
But central apnea, which is highly prevalent in PURA, is a completely different mechanism.
Central apnea is a software failure, not a hardware blockage. Remember how we said the pure alpha protein is highly expressed in the brain?
Right.
It's heavily concentrated in the brainstem. The brainstem is the primitive lizard part of our brain that sits at the top of the spinal cord. It controls automatic, subconscious functions like heart rate and the biological drive to breathe.
Okay.
In central apnea, the baby's airway is perfectly open, but the brainstem simply forgets to send the electrical signal down the phrenic nerve to the diaphragm.
The command to take a breath is just never issued.
The site manager just drops the radio. No signal goes out.
The result is that the baby just stops breathing without any signs of struggle or gasping.
None at all. Which is exactly why the continuous oxygen monitoring in the NICU is the only thing keeping them alive. They won't gasp to alert you.
And the third part of the triad ties directly into this lack of muscle coordination. Severe feeding difficulties, technically known as dysphagia. Over 80% of infants with PURA syndrome have this.
Swallowing is an incredibly complex mechanical act. People don't realize it. It requires the perfect split-second coordination of the suck, swallow, breathe cycle.
You have to close off the airway, open the esophagus, and push the liquid down, all while managing your breath.
When you have severe oromotor hypotonia, meaning the muscles in the face, mouth, and throat are floppy, the baby simply cannot form a seal to suck effectively. But more dangerously, the timing is off.
Meaning milk can go the wrong way.
Yes, milk can bypass the closed-off esophagus and slip directly down the trachea into the lungs.
Which causes aspiration pneumonia, a life-threatening infection. So you're in the NICU, the alarms are going off, and this triad is presenting. What is the neonatologist actually doing to stabilize the child? What are the immediate interventions?
The neonatologist's immediate priorities are securing the airway and ensuring safe caloric intake. For the central apneas, the baby will likely be placed on mechanical ventilation, where a machine breathes for them, or CPAP.
Continuous positive airway pressure?
Right. CPAP pushes a constant stream of pressurized air into the nose, which forces the floppy airway open and stimulates the lungs to remind the brain to keep working.
And for the feeding, if they can't swallow safely, how do they grow?
The team will bypass the mouth entirely. Initially, this involves dropping a nasogastric, or NG tube, through the baby's nose, down the back of the throat, and directly into the stomach. Formula or breast milk is just pumped right in.
But that's temporary, right?
Yeah. If the swallow studies show that the dysphagia is chronic and severe, the CEO parent will have to consult with a pediatric surgeon. They will surgically place a G tube, a gastrostomy tube, directly through the skin of the abdomen into the stomach.
That sounds intense for a baby.
It is, but it ensures the child can receive full nutrition and hydration safely, completely eliminating the risk of aspiration pneumonia.
There's also mention in the clinical guides of these babies suffering from hypothermia in the NICU. Why are they getting so dangerously cold?
It comes right back to the dysfunction in the brainstem. The brainstem is home to the hypothalamus, which acts as the body's internal thermostat. It regulates autonomic functions like sweating and shivering.
So with the pure alpha protein disrupted, that thermostat is basically broken?
Yes. The baby cannot regulate their own core temperature. The NICU team has to place them in specialized servo-controlled warming incubators to prevent fatal hypothermia.
I want to pause here and ask a practical question. With all these severe symptoms at birth, floppiness, breathing issues, feeding problems, how do doctors in the NICU actually know they are dealing with PURA syndrome?
That's the thing.
Right. A floppy baby with breathing trouble seems like it could be 100 different genetic or metabolic disorders. How do they know what they were looking at before the genetic test comes back a month later?
The reality is, in those first few frantic days, they don't know it's PURA syndrome. This is the differential diagnosis phase. The neonatologist is looking at a severely hypotonic infant and has to systematically rule out other high-priority, life-threatening conditions.
What are the primary suspects they are trying to eliminate?
Two of the most common genetic suspects for profound neonatal hypotonia are Prader-Willi syndrome, or PWS, and spinal muscular atrophy, or SMA. PWS presents very similarly at birth, but the doctors will look for subtle clinical clues, specific facial features like almond-shaped eyes, underdeveloped genitals.
And PWS leads to a different path later, right?
Right. The knowledge that PWS eventually leads to a completely different trajectory later in childhood involving hyperphagia and insatiable hunger, which is totally absent in PURA.
But SMA, spinal muscular atrophy, that is a devastating, often fatal muscle disease. Distinguishing between SMA and PURA seems absolutely critical.
It is the most critical distinction they make, and it often comes down to a remarkably simple clinical test.
Really? What is it?
If a pediatric neurologist takes a reflex hammer and taps the knee of a baby with spinal muscular atrophy, they will get absolutely no response.
Nothing at all.
Nothing. SMA is the disease of the peripheral nervous system. The motor neurons in the spinal cord are dying, so the reflex arc is completely broken.
But what happens when they tap the knee of a baby with PURA syndrome?
This is the vital clinical clue. Despite the profound, severe floppiness of the baby's body, when you tap the knee of a baby with PURA, their deep tendon reflexes are typically preserved. Their knee will jerk.
Wait, if they are completely floppy, how can they have a strong reflex?
Because the local circuitry, the sensory nerve traveling from the knee to the spinal cord, and the motor nerve traveling back to the leg, is structurally intact. The muscles themselves are fine, the peripheral nerves are fine.
The problem is central.
Yes. The brain, high up in the skull, is failing to send the overriding signals down the spinal cord to establish muscle tone. That simple tap of a reflex hammer shifts the entire diagnostic trajectory from a peripheral muscle disease to a central brain development disorder.
That is fascinating. It proves the plumbing is intact. It's the central water pressure that's missing. Now, while this NICU phase is undeniably traumatic, the clinical data provides a very important piece of hope regarding these respiratory issues.
Yes, it does. While the central apneas are terrifying in infancy, the longitudinal data shows that they often show gradual improvement or even resolve entirely after the child's first birthday.
So the brainstem eventually matures just enough to take over the baseline job of breathing.
In many cases, yes. The acute crisis subsides. The child learns to breathe consistently. The G-tube handles the feeding. You survive the most terrifying year of your life. The neonatologist discharges you, and you finally bring your child home.
But as the CEO, you quickly realize the battle is simply shifting. It's no longer about minute-to-minute survival. It's about mapping out their entire developmental future.
Which brings us to the next major division of your A-team, the neurological trajectory and the therapy team.
The child is growing, and your boardroom expands significantly. We are talking about pediatric neurologists, epileptologists, and a whole squad of specialized therapists.
Physical, occupational, and speech-language pathologists. They become the daily operational managers of your child's life.
And for this team to be effective, the parents must understand the fundamental nature of what they are treating. The sources explicitly state that PURA syndrome causes moderate to profound intellectual disability. But crucially, it is categorized as a neurodevelopmental condition, not a degenerative one.
That is a massive life-altering distinction.
Walk us through what that means for a parent's day-to-day outlook.
Well, a degenerative condition like Tay-Sachs or certain types of leukodystrophy means a child gains skills. They learn to babble, to sit up, maybe to walk, and then the brain begins to deteriorate. They slowly lose those skills and regress.
It's heartbreaking.
It is, but PURA syndrome is not that. Skills are not lost. They're just severely, profoundly delayed.
Okay.
The developmental gap between a child with PURA and their typically developing peers will widen significantly over time, but the child is almost always moving forward at their own unique pace. Slow, hard-won progress continues throughout life.
Let's look at the physical milestones. What exactly is the physical therapist dealing with? If the muscles themselves are healthy, why is movement so hard?
The physical therapist is battling that chronic central hypotonia. Because the brain isn't sending strong, continuous signals to the muscles to maintain tone, the child has to use immense voluntary effort just to move against gravity.
It must be exhausting.
Very exhausting. Achieving gross motor milestones is incredibly difficult. Independent walking is often not achieved at all by a significant portion of the population.
And if they do walk?
If independent walking is achieved, it is usually remarkably late, typically anywhere between the ages of 3 and 10. And when they do walk, it is rarely a smooth, typical stride. It's usually a wide-based, unsteady gait.
They keep their feet far apart to compensate for the lack of core stability.
Yeah, which makes them highly prone to fatigue and falls.
Yeah.
Therefore, the PT's job isn't just about forcing the child to walk. It's about providing durable medical equipment, gait trainers, specialized supportive walkers, and custom-molded seating systems for their wheelchairs.
To maximize whatever functional capacity the child has while protecting their spine and joints.
Exactly.
But the most emotionally complex area of development, and the one heavily highlighted in the literature, is language. The speech and language therapist has an incredibly unique challenge with PURA syndrome. There is a massive discrepancy noted between receptive language and expressive language.
Yes, this discrepancy is a real hallmark of the syndrome. The vast majority of individuals with PURA are non-speaking or nonverbal throughout their entire lives.
They physically cannot articulate meaningful spoken words.
Right, due to the severe oromotor hypotonia and apraxia. Apraxia is the brain's inability to coordinate the mouth, tongue, and vocal cords to form sounds. However, parents and clinicians consistently report that these patients demonstrate a surprisingly high level of receptive language.
They understand what is happening around them.
Precisely. They can follow simple and sometimes quite complex commands. They recognize people, they understand routines, they laugh at jokes.
Here's where it gets really interesting. The best way I can visualize this is like an audio setup. It's like these children have a state-of-the-art receiver that catches every single radio broadcast perfectly.
Yeah, they hear the music, they process the news, they understand the signal.
But their microphone is completely unplugged. The physical mechanism to broadcast their thoughts back out to the world is severed.
That analogy perfectly captures the daily reality. They are taking everything in. And furthermore, the behavioral profile of children with PURA syndrome is overwhelmingly described as highly social, loving, friendly, and deeply affectionate. They possess a strong, innate desire to interact with their families.
But if a child has all this social desire and cognitive understanding trapped inside a body that cannot speak, it eventually leads to immense frustration.
It absolutely does.
Which makes total sense. If I knew the answer to a question and literally couldn't make my mouth form the words, I would want to scream or throw something. So how does the speech therapist bridge that gap? If the microphone is unplugged, how do they give these children a voice?
Through the absolute necessity of early augmentative and alternative communication, known as AAC. The clinical guidelines stress that AAC must be implemented as early as possible. And this isn't just about handing a toddler an iPad and hoping for the best.
Right.
It is a highly calibrated, tiered approach based on the child's specific motor control.
What does that progression look like?
Well, it might start with low-tech options. Keyword sign uses simplified sign language for basic needs, though the hypotonia often makes hand signs difficult. They might use physical symbol boards, where the child uses a fist or a finger to point to a picture of water or play.
And then as they grow and their cognition develops...
The therapist will introduce high-tech, touchscreen, speech-generating devices.
But what if their hypotonia is so severe that they don't have the fine motor control to accurately point a finger at a screen?
This is where modern technology is truly miraculous. For those children, therapists utilize advanced eye gaze technology.
Eye gaze.
Yeah. The AAC device has infrared cameras built into the frame that track the exact micro-movements of the child's pupils. The child simply has to look at a specific icon on the screen, say a picture of their mother, for a preset amount of time known as dwell time, and the computer will speak the word out loud.
That is incredible. They can literally speak with their eyes. But calibrating that must be incredibly fatiguing for the child.
It requires immense cognitive load and visual tracking skills, which is exactly why the speech therapist works so closely with the occupational therapist to ensure the child's seating system perfectly supports their head so their eyes can focus. When AAC is successfully implemented, it drastically reduces behavioral outbursts because the child finally has a way to exert control over their environment.
So the therapists are working miracles to unlock the child's potential, but there is a very dark cloud that hangs over the neurological trajectory of PURA syndrome, a complication that can severely derail all this developmental progress. And that is epilepsy.
Yes.
The neurologist, or specifically the specialized epileptologist, has a daunting task here.
The neurological burden of epilepsy and PURA is severe. The clinical data indicates that epilepsy affects more than 50% of individuals with the syndrome. The onset typically occurs between the ages of 2 and 5, though it can certainly happen earlier in infancy. And this is not a straightforward, easily managed type of epilepsy.
Walk us through what the parents are actually seeing. What do these seizures look like?
The epilepsy is highly complex and often evolves in its presentation. Many patients start with myoclonic jerks.
Myoclonic jerks.
Yeah, these are sudden, involuntary, lightning-fast muscle twitches, often involving the arms or upper body. They might look like the child is just startled, but they are actual electrical misfires in the brain. They can be incredibly frequent, occurring dozens of times a day, severely disrupting the child's ability to focus on therapy or AAC.
And it progresses from there?
Unfortunately, yes. Over time, the epilepsy often progresses to generalized tonic-clonic seizures. These are what most people think of when they hear seizure, convulsive, full-body shaking, accompanied by a complete loss of consciousness.
They are terrifying for parents to witness.
Very much so. And they carry a high risk of physical injury. More concerningly, they carry the risk of scatus epilepticus, which is a prolonged seizure that won't stop on its own and requires emergency rescue medication to prevent brain damage. In a significant number of cases, the condition evolves into Lennox-Gastaut syndrome.
Lennox-Gastaut. I've heard that term in the context of very severe neurological disorders. What makes it so specifically dangerous?
Lennox-Gastaut syndrome is a severe epileptic encephalopathy. It is characterized by a triad of features, multiple different types of seizures occurring in the same patient, specific, highly abnormal slow spike and wave patterns on an EEG, and tragically, cognitive regression or stagnation.
Oh, wow.
The brain is so overwhelmed by continuous electrical storms that learning becomes nearly impossible. And Lennox-Gastaut is notoriously refractory, meaning it is highly resistant to standard anti-seizure drugs.
So as the CEO of this medical team, you are looking to your lead neurologist. If the standard drugs don't work, what is the playbook? How do they handle refractory seizures?
The epileptologist has to rely on polytherapy, using multiple powerful anti-seizure medications in careful combination, hoping the synergistic effect will suppress the electrical storms without completely sedating the child. But managing this requires absolute precision, which is why serial EDs and continuous video EG monitoring in the hospital are essential.
Why is the video component so important? Can't they just look at the brain waves?
Because children with PURA syndrome also suffer from a variety of non-epileptic movement disorders. The video is crucial for distinguishing them. For instance, they have dystonia, which are slow, twisting, involuntary muscle contractions.
Right.
They have stereotypes, which are repetitive, non-functional movements like intense hand flapping or biting. And they have a very specific pathological startle response, known as hyperacusis.
Explain the startle response. We all jump when a door slams.
Yes, but in a child with PRA, an unexpected noise or touch triggers an exaggerated, prolonged physical reaction. Their arms might fly up, their body might go rigid, and they might cry out. To a parent or even a less experienced doctor, a severe startle response or a dystonic twist looks exactly like a seizure.
But it's not.
Exactly. The epileptologist has to look at the video of the movement and the EEG brainwaves simultaneously to tell the parent, that arm flail was just a startle response. The brainwaves were normal, but that subtle eye twitch 5 minutes later, that was a seizure. You only want to medicate the actual seizures because anti-seizure meds have heavy cognitive side effects.
I see. If you medicate a startle response with anti-seizure drugs, you are just heavily sedating the child for no reason. Now, what about surgery? We often hear about epilepsy patients having the focal point of their seizures surgically removed.
That works well for focal epilepsy, where a scar or a tumor in one specific part of the brain is generating the spark. But remember our skyscraper blueprint. The PRA genetic defect is expressed in every single cell throughout the entire brain.
The whole building is wired wrong.
Right. There is no single focal point causing the seizures. The electrical storms are generalized. Therefore, surgical resection, cutting out a piece of the brain, is simply not an option.
So if drugs fail and surgery isn't an option, what tools are left in the toolbox?
The epileptologists have to look at alternative non-pharmacological treatments. This includes devices like vagus nerve stimulation, VNS, which acts like a pacemaker for the brain, or specialized dietary therapies. And there is a very compelling piece of clinical data published in early 2024 regarding dietary intervention.
Oh.
A paper in the journal Genes detailed a specific case study of an 11-year-old boy with PURA syndrome.
Walk us through that case.
This boy had a de novo frameshift variant in his PURA gene. He actually had a seizure-free period in early childhood, but at age 7, he developed severe epileptic spasms, up to 30 violent episodes a day.
30 a day! You can't learn, you can't go to therapy, you can barely sleep. That is no way to live.
It is devastating. The medical team put him on Valproate, a heavy, standard anti-seizure drug, but he had to stop after 6 months due to severe side effects. They tried levetiracetam, another standard drug, but it failed to control the spasms. Out of options, the medical team admitted him to the hospital to initiate the ketogenic diet.
The ketogenic diet. We hear about this as a weight loss fad, but it was actually invented for epilepsy, right? High fat, extremely low carbohydrate. How does eating fat stop electrical storms in the brain?
The mechanism is fascinating. The human brain normally runs on glucose, derived from carbohydrates. When you drastically restrict carbohydrates, the liver begins breaking down fats into molecules called ketone bodies. The brain switches its fuel source from glucose to these ketones.
Okay.
Running the brain on ketones fundamentally alters neuronal excitability. It increases the production of GABA, which is an inhibitory calming neurotransmitter, and decreases glutamate, which is an excitatory neurotransmitter. It literally changes the chemical environment of the synapses, making it harder for a seizure to spark and spread.
And what happened to the 11-year-old boy?
The results were remarkable. The diet successfully drastically reduced his refractory seizures. But it did something else entirely unexpected. It resolved a secondary chronic issue he was suffering from, severe sialorrhea, which is excessive drooling.
Wait, how does a high-fat diet cure drooling?
Drooling in PRA syndrome isn't caused by making too much saliva. It's caused by the oromotor hypotonia, the floppy facial muscles, and the lack of coordination required to subconsciously swallow normal amounts of saliva. Because the ketones stabilize the global neuronal networks in his brain, his overall neuromuscular coordination slightly improved.
Just enough.
Just enough. The baseline electrical signaling to his throat improved just enough that his automatic swallowing reflex began to function properly. This was the first documented clinical case showing an improvement in both seizures and sialorrhea with the ketogenic diet in a PURA patient.
That is a massive win for that family and a perfect example of why the CEO needs a specialist who knows the latest literature. Now, because refractory epilepsy is so desperate, I often see chatter in parent forums about other drugs, people discussing off-label things like salbutamol or pyridostigmine, sharing dosages online. What does the actual clinical literature say about those?
The clinical literature is extremely cautious, and as a medical analyst, I must urge parents to be equally cautious. The medical data notes that while there are individual anecdotal reports of these drugs being used by some families, their efficacy is completely unproven in clinical settings.
There's no hard data.
There is a profound lack of standardized, peer-reviewed clinical trials for these specific drugs in PURA syndrome.
So it's essentially experimental.
Highly experimental and highly controversial within the medical community. The neurological system of a child with PURA is incredibly fragile. Any use of off-label medication must be done under the strict, rigorous oversight of your lead epileptologist. Do not experiment with dosages based on Facebook groups. The risk of triggering status epilepticus or dangerous drug interactions is simply too high.
A vital warning for any CEO. Never implement an experimental patch to the system architecture without consulting your lead engineer.
Exactly. The consequences are too severe.
Which brings us to a major pivot in our deep dive. We've spent the last half hour talking exclusively about the brain, central apneas, the hypotonia, the speech delays, the seizures. But if I'm a parent looking at my child's massive medical chart, I also see recurring appointments for an orthopedist, an endocrinologist, an ophthalmologist, and a gastroenterologist. Why?
Oh, right.
If this is a neurogenetic disorder, why are all these bodily organs failing? This brings us to the next phase of our A-team, beyond the brain and the extra neurological specialists.
It is a very common misconception that neurogenetic disorders only affect the nervous system. To understand why your child needs this extensive team, we have to look back at the biology we discussed at the very beginning. The pure alpha protein isn't just floating around in the brain.
It's everywhere.
It is highly conserved and essential for cellular homeostasis across nearly all human tissues. It's in the heart tissue, the skeletal muscle, the blood vessels, the bones, the endocrine glands. Therefore, the loss of this master protein results in a true multisystemic condition. The body's entire infrastructure is compromised.
Let's walk through these specialists and map out exactly what they're managing, starting with the orthopedist. They are dealing with the bones and the skeleton. If the primary symptom is hypotonia, floppy muscles, how does that break the skeleton?
It's a mechanical downstream effect. The human skeleton does not grow straight and strong entirely on its own. It relies on the dynamic tension of the surrounding muscles pulling against the bones. It requires weight-bearing exercise, standing, walking, running, to stimulate bone growth and joint formation.
But these kids aren't doing that.
Right. Because children with PURA have chronic, severe low muscle tone, and because they're often largely sedentary or confined to customized wheelchairs, their skeletal system is placed under immense abnormal biomechanical stress.
And the most visible, drastic result of that abnormal stress is severe scoliosis.
Yes, scoliosis, or the lateral curvature of the spine, is a major complication, reported in approximately 48% of the PURA population.
Really half.
Nearly half. And we have to be clear, this is not just a cosmetic issue where the back looks slightly crooked. The spinal curvature in these children is often highly progressive, meaning it accelerates rapidly as they grow through childhood and into puberty.
What happens if it's left untreated?
The spine will continue to curve and twist, eventually forming a severe C or S shape. This twisted spine will literally compress the chest cavity, crushing the lungs and the heart, causing fatal pulmonary compromise. Furthermore, a twisted spine makes it impossible for the child to sit comfortably in their specialized wheelchair, leading to pressure sores and immense chronic pain.
So they track it closely.
The orthopedist is tracking this curve meticulously with X-rays. In many cases, conservative treatments like back braces fail, and the orthopedic surgeon must perform a major spinal fusion, inserting titanium rods and screws to manually straighten and stabilize the spine.
The sources also mention hip dysplasia as a frequent orthopedic issue.
Again, this is a mechanical failure. The hip joint is a ball and socket. In a typical toddler, the act of standing and walking drives the ball of the femur deep into the pelvis, forcing the socket to form a deep, secure cup around it.
But without that weight bearing.
Because a child with PURA isn't standing and walking early on, that mechanical pressure never happens. The socket remains shallow. The ball of the femur can easily subluxate or slip out of the joint entirely. This causes excruciating pain, limits their ability to tolerate physical therapy, and often requires reconstructive orthopedic surgery.
So the orthopedist is managing the visible architecture, the spine, and the hips, but there's also an invisible bone issue happening, right? Something a parent might not notice until a catastrophe occurs.
You're referring to bone mineral density.
Yeah.
This is a critical and tragically often overlooked aspect of PURA care. Many individuals with PURA demonstrate dangerously low bone mineral density, leading to osteopenia or outright osteoporosis at very young ages.
Why are their bones so weak?
It is a perfect storm of three factors. First, the lack of weight-bearing mobility means the bones aren't stimulated to absorb calcium. Second, they often have a metabolic dysfunction leading to severe vitamin D deficiency. And third, and perhaps most importantly, the heavy anti-epileptic medications they take to control their seizures, drugs like valproate, actively alter bone metabolism.
They literally leach calcium out of the bones.
Yes, over years of use.
So their bones become brittle from the inside out.
Yes, the clinical term for the result is pathological fractures. This means a bone breaks not from a major trauma like a car crash or a fall from a playground, but from normal daily activity or minimal trauma. A parent simply moving the child from the bed to the wheelchair, or a physical therapist doing routine stretching exercises, could easily snap a femur if the osteoporosis is severe enough.
That is terrifying.
This is why regular Decoding scans, which measure bone density and aggressive vitamin D and calcium supplementation, are mandatory parts of the medical plan.
Okay, let's move to the next specialist on the list, the endocrinologist. We usually associate endocrinology with hormones, diabetes, thyroid issues. What exactly are they doing on the PURA team?
The clinical data from the latest comprehensive guides points to increasing evidence that PURA syndrome is directly associated with dysfunction of the anterior pituitary gland.
The master gland.
Yes, it's a pea-sized structure sitting right at the base of the brain, and it regulates major hormonal pathways throughout the body. The PURA alpha protein is highly involved in regulating the transcription of these pituitary hormones. When PURA alpha is missing, the endocrine signals misfire.
How does that pituitary dysfunction actually manifest in the child's life? What is the parent dealing with?
It manifests primarily in growth and sexual maturation. While birth weights and lengths are usually completely normal, their growth patterns often deviate significantly over time. They might suddenly drop off the growth chart, requiring the endocrinologist to monitor for growth hormone deficiency and potentially initiate daily growth hormone injections. But the most disruptive issue involves puberty.
The guidelines note that both precocious, meaning early onset, and delayed puberty are documented.
Yes, the anterior pituitary controls the release of gonadotropins, which signal the body to begin puberty. In some children with PURA, the system activates far too early. We see cases of precocious puberty starting at age 7 or 8.
At 7 years old.
Imagine a nonverbal child, already struggling with severe cognitive and motor delays, suddenly having to deal with the intense physical changes, the hormonal surges, and the emotional volatility of puberty years earlier than their peers. It causes massive behavioral disruptions. The endocrinologist manages this by prescribing hormonal suppression therapy, essentially pausing puberty chemically to align their physical maturation with a safer, more appropriate timeline.
We also have the ophthalmologist checking their eyes regularly. It's not just about needing glasses, is it?
The visual impairments are highly prevalent and structurally complex. Strabismus, which is the misalignment of the eyes or crossed eyes, is the most frequent finding. The hypotonia affects the tiny muscles that control eye movement, meaning the eyes can't track together. They also have significant refractive errors, primarily severe myopia or short-sightedness. Some patients even present with a rare condition called Brown syndrome, which is a mechanical problem with the superior oblique tendon sheath that physically limits the eye's ability to look upward.
And lastly on our extra neurological list, the gastroenterologist. We touched on the G-tubes and feeding issues in the NICU, but the GI issues persist long after they learn to eat or use the tube, right?
The GI issues are almost universal. Chronic, severe constipation is a relentless daily complaint among caregivers. The parent has to understand that the hypotonia doesn't just affect the skeletal muscles in the arms and legs, it also affects the smooth muscle lining the intestines. The gut itself is floppy.
Oh, wow.
It lacks the strong peristaltic waves, the muscular contractions, needed to push waste through the digestive tract.
Wait, so the constipation isn't a diet issue, it's a mechanical issue. The
Yeah.
plumbing lacks the pressure to move the waste.
Exactly. Add to that the lack of physical activity, which normally helps stimulate the bowels, and you have severe painful constipation that can lead to bowel impaction. Diet alone cannot fix it. The gastroenterologist has to implement highly regimented daily use of osmotic laxatives.
What does an osmotic laxative do?
Drugs like polyethylene glycol work by osmosis. They physically draw water from the surrounding tissues directly into the colon, softening the stool so much that it can pass without requiring strong muscular contractions from the floppy intestines.
So, as the CEO parent, you are managing a schedule of spinal x-rays, bone density scans, puberty-blocking hormones, eye muscle surgeries, and daily bowel regimens, all on top of the severe epilepsy and the communication therapies. It is an incredibly heavy load. It feels like you have to be a project manager just to keep the plates spinning. Is there one specific area outside the brain that parents should prioritize? Where does the CEO need to direct their focus to prevent a systemic collapse?
If we connect this to the bigger picture of the child's quality of life, you must fiercely prioritize bone health and vision. Think back to our discussion about the speech therapist and communication. We established that for many of these children, their only way to speak to the world is through a high-tech visual eye gaze AAC device.
Right, the eye tracking.
What happens if their strabismus goes uncorrected and their eyes can't calibrate with the infrared cameras? Or if their myopia is so bad they literally can't focus on the screen icons? Uncorrected vision physically isolates them inside their minds. They lose their voice entirely.
Oh, wow. I hadn't connected those dots. If they can't see the screen, they are trapped.
Exactly. It's a cascading failure. And regarding bone health, a pathological femur fracture from untreated osteoporosis will strip away whatever hard-won physical independence they have achieved in physical therapy. It will cause immense pain, require powerful painkillers that sedate them, and necessitate weeks of hospitalization that completely disrupt their strict daily routines, often leading to severe behavioral regression.
So it's all connected.
Routine monitoring by the orthopedist and ophthalmologist isn't just a medical precaution. It directly protects the child's daily ability to engage, communicate, and live without constant pain.
Which perfectly transitions us into the next phase of our medical management. Because if your child has severe progressive scoliosis, or if they need a G-tube surgically placed for feeding, or if they need eye muscle surgery to fix that strabismus so they can use their AAC device, they are going to need an operation.
Yes.
This brings a specialist to the table who is absolutely critical, holding the child's life in their hands, but who is often totally overlooked until the morning of the surgery: the anesthesiologist.
And we must be incredibly clear about this. Placing a child with PURA syndrome under general anesthesia is arguably the most dangerous high-risk juncture of their entire medical journey. Putting a patient with severe central hypotonia and brainstem dysfunction to sleep carries radically elevated life-threatening risks.
And the medical community knows this, right?
Yes, the medical community recognized this specific danger, which is why there are dedicated orphan anesthesia guidelines published internationally exactly for PURA syndrome.
So as a parent, you shouldn't just assume the hospital's standard pre-op anesthesia protocol is going to be fine.
Absolutely not. You cannot rely on standard protocols. As the CEO, you must print out the orphan anesthesia guidelines and physically hand them to the surgical and anesthesia team during the pre-op consultation weeks before the surgery. You have to advocate fiercely.
What exactly do those guidelines mandate? Why is standard anesthesia so dangerous for them?
It comes down to an extreme pathological respiratory sensitivity. The drugs used to induce and maintain general anesthesia, sedatives, opioids, benzodiazepines, naturally depress the respiratory drive in the brain. In a healthy person, the anesthesiologist knows exactly how much to give to keep them asleep but breathing or easy to ventilate. But a child with PURA syndrome already has a compromised brainstem that struggles to drive breathing on a good day. If you give them a standard dose of these depressants, you tip that fragile system into complete cessation. They demonstrate an intense, hypersensitive, prolonged reaction to these drugs.
So what is the anesthesia team supposed to do?
The orphan anesthesia guidelines explicitly recommend that the anesthesiologist reduce the doses of opioids and benzodiazepines by approximately 50%.
Cut the powerful drugs in half. That is a massive clinical deviation. What happens if an anesthesiologist ignores the guidelines and gives the standard dose?
The patient will likely suffer from severe delayed recovery. This means the surgery ends, the breathing tube is removed, but the child simply won't wake up. Their brainstem won't start signaling for spontaneous breaths for hours or sometimes days after the surgery. They end up intubated in the pediatric intensive care unit.
Let me ask a practical logistical question here. Let's say a child just needs a quick minor procedure, maybe getting a new G-tube button placed or a quick dental surgery to remove a cavity. Can't they just go to a local outpatient ambulatory surgery center, get it done in 20 minutes, and go home the same afternoon to sleep it off in their own bed? It's so much less stressful for the child than staying in a hospital.
The orphan anesthesia guidelines strongly, unequivocally caution against this. Ambulatory or day surgery is explicitly not recommended for individuals with PURA syndrome under any circumstances involving general anesthesia or deep sedation.
Even for a 20-minute dental procedure.
Even for a 20-minute dental procedure, the risk of post-anesthetic central apneas and obstructive apneas is simply too high. When they go home, parents do not have the hospital-grade continuous monitoring required to detect if the child's brainstem suddenly stops signaling for breaths while they are sleeping off the anesthesia. The guidelines mandate that any patient with PURA syndrome must be formally admitted to the hospital for a minimum of 24 hours of continuous pulse oximetry and respiratory monitoring following any procedure.
They need the alarms and the nurses right there, watching the oxygen levels all night. Okay. What other specific precautions are required while the child is actually on the operating table?
There are three other major physiological vulnerabilities the anesthesiologist must manage differently. First, during induction, putting them to sleep, and recovery, waking them up, there is a massively increased risk of aspiration.
Because of the hypotonia?
Right. Because of that severe oropharyngeal hypotonia, the floppy throat muscles we discussed regarding feeding, stomach contents, and secretions can easily pull and slip past the vocal cords into the lungs, while the protective reflexes are suppressed. The guidelines suggest the prophylactic use of a nasopharyngeal airway.
What is that?
It's a soft, flexible tube placed through the nostril, down the back of the nose, and into the throat. It physically holds the floppy tissue of the upper airway open, providing a clear channel for air and allowing the anesthesiologist to suction out secretions safely during awakening, preventing the airway from collapsing on itself.
To literally prop the throat open. Got it.
What's the second vulnerability?
Temperature control. Remember the brainstem dysfunction causing severe hypothermia in the NICU. That happens on the operating table, too. The cold operating room environment, combined with the anesthetic drugs, completely knocks out the autonomic nervous system's ability to regulate core heat.
So they get dangerously cold. The child will not shiver to keep warm. The surgical team must deploy active warming measures, like forced air warming blankets and warmed 5E fluids, throughout the entire procedure to prevent severe intraoperative hypothermia, which can delay recovery and affect blood clotting.
And the third major vulnerability?
Seizure management. Think about the logistics of surgery. The patient must be NPO, nil per os, meaning nothing by mouth, for 8 to 12 hours before surgery to prevent aspiration.
That means they cannot swallow their crucial scheduled doses of oral anti-epileptic pills.
Exactly. But missing even one dose of polytherapy in a patient with refractory epilepsy could trigger life-threatening status epilepticus right there on the operating table.
So how do they get the meds in?
The anesthesiologist and the epileptologist must coordinate closely to calculate and administer intravenous, or IV, substitutes of all their seizure medications while they're NPO. The parent's job, as the CEO, is to rigorously audit this plan before the child goes back to the OR. You ask the anesthesiologist point blank, how are we doing the half-dose opioids? Where's the active warming blanket? Have you ordered the IV seizure meds? And is the 24-hour post-op ICU bed reserved?
That is incredibly empowering for a parent. It fundamentally changes the dynamic. You move from sitting in the waiting room just hoping for the best to actively managing the risk parameters with the medical team, ensuring the blueprint of your child's specific needs is followed to the letter.
Precisely. Turns the parent in the ultimate safety advocate. You are enforcing the operational guidelines.
Which takes us to the final part of our deep dive today. We've mapped out the vast team needed to survive the NICU, to unlock communication through AAC, to manage the bones and hormones, and to survive the intense risks of surgery. But what happens next? As these children who were first diagnosed back in 2014 grow up, what does the future hold? This brings us to adulthood, advocacy, and the 2026 research pipeline.
The first, most vital piece of information regarding the future is that survival into adulthood is the expected outcome.
That's amazing.
It is, because the syndrome is a neurodevelopmental condition, not a degenerative one. As long as major acute complications like status epilepticus, severe scoliosis, or aspiration pneumonia are effectively managed by the A-team, these individuals live long lives.
Yeah.
The PURA Syndrome Foundation has identified adults living with the condition in their 30s, 40s, and even into their 50s.
That is wonderful news, but it also presents a massive looming logistical challenge for the parents. A 45-year-old adult with profound intellectual disability and severe mobility issues requires a very different care structure than a 5-year-old.
The logistical mountain is immense. The clinical guides clearly state that transition planning must start early, ideally when the child is around 12 years old. The parents have to start thinking about the legal architecture. Who holds legal guardianship or medical power of attorney when the child legally becomes an adult at 18?
That's a lot of paperwork.
It is. And you have to navigate the incredibly complex shift from pediatric specialists who are highly accustomed to dealing with rare genetic anomalies to adult medical specialists who may have literally never heard of PURA syndrome in their entire careers.
You essentially have to train a whole new A-team from scratch.
Yes. You also have to identify and secure funding for adult day programs, supported living environments, or residential facilities that are actually equipped to handle nonverbal adults who rely on eye-gaze communication, G-tubes, and complex seizure management. The CEO parent has to plan for their own succession. What happens to the infrastructure when the parents are too old to physically lift their adult child?
And behaviorally, the landscape changes too, right? A frustrated toddler throwing a tantrum because they can't communicate is one thing. A frustrated, full-grown adult is a very different physical reality.
The behavioral shifts during the teenage years and early adulthood are highly significant. The literature notes that while these individuals remain generally loving and highly social, the accumulated stress of the condition takes a toll. They can develop severe anxiety, which is often triggered by sensory overload in busy environments or by unexpected changes to their strict daily routines.
Do we see other behavior changes?
We also see an increase in sensory seeking or sensory avoidance behaviors. Intense hand flapping, biting, or extreme aversive reactions to specific textures or sounds.
And what happens when that frustration boils over?
Most concerningly, the profound frustration of being a grown adult with complex emotional desires, still trapped behind a severe communication barrier, can sometimes manifest as self-injury or physical aggression. This is why consistent, lifelong access to AAC communication support, occupational therapy for sensory regulation, and sometimes psychiatric care to manage anxiety become absolutely vital components of the adult care plan.
It is a heavy load to carry. It's a lifetime appointment as CEO. But parents are not carrying it alone or in silence. The advocacy and research landscape for PURA syndrome has exploded over the last decade. It's not just parents sitting at home hoping scientists will care.
It is truly one of the most remarkable stories in modern rare disease advocacy. When you are dealing with an ultra-rare disease, remember, only about 706 confirmed cases globally. As of late 2024, pharmaceutical companies are not naturally incentivized to study it. Therefore, global patient advocacy groups are not just emotional support systems. They are the actual, literal engine driving scientific progress. The PURA Syndrome Foundation is the primary international organization, and their approach is highly sophisticated. They don't just host meetups. They run the Global Patient Registry.
What exactly is a patient registry?
It is a massive longitudinal natural history study currently operated in collaboration with researchers at the University of Southampton. Parents log in and painstakingly record every symptom, every seizure, every medication change, and every developmental milestone over years and years. They are tracking exactly how the disease behaves across the entire global population.
They are mapping the enemy.
Yes. They also run the Global Biobank. Parents coordinate to have skin biopsies drawn from their children or blood drawn, and those physical cell lines are stored in a centralized vault to be distributed to researchers worldwide. They have programs like GrandPOPS for grandparents and dedicated sibling outreach. The community is deeply mobilized.
So what does this all mean? With all these researchers across the globe, how close are we actually getting to treatments that go beyond just managing symptoms with laxatives and seizure meds? Are we getting close to actually fixing the broken blueprint?
We are closer than anyone thought possible 10 years ago. Look at the timeline. From a total clinical curiosity in 2014 to actionable therapies moving into preclinical trials today. A landmark development occurred recently, spearheaded by the collaboration between the Jackson Laboratory, a premier genetics research institution, and a parent-led nonprofit called Jack's Tomorrow. Using CRISPR-Cas9 gene editing technology, they created a knockout mouse model for PURA syndrome.
Let's explain that. What is a knockout mouse and why is CRISPR involved?
CRISPR-Cas9 is essentially microscopic genetic scissors. The researchers used these scissors on mouse embryos to literally snip out and break or knock out one copy of the mouse's PURA gene, perfectly replicating the human haploinsufficiency. They created a living, breathing mammalian model that actually exhibits the fatal seizures, the severe hypotonia, and the motor deficits seen in human children with PURA syndrome.
Why is a mouse model such a monumental big deal? It sounds cruel, but why is it biologically necessary?
Because without a reliable animal model that mirrors the human disease, you cannot test gene therapies. You can't test a drug that alters brain chemistry on a human child first. The mouse is a required proving ground. If researchers develop a targeted genetic therapy that forces the healthy copy of the PURA gene to work twice as hard, they inject it into the knockout mouse.
And see what happens.
If the mouse's seizures stop and its muscle tone improves, they know they have a viable drug candidate for humans. In parallel to this, you have researchers like Professor Chris Reed at the Florey Institute in Australia doing massive, highly funded studies on precision epilepsy treatments using these advanced models.
And the regulatory agencies like the FDA are starting to adapt their incredibly slow rules to accommodate this new technology, right?
Yes, the regulatory landscape is shifting. The FDA is opening a new route called the plausible mechanism pathway for individualized ultra-rare disease drugs. Historically, to get a drug approved, you needed a phase 3 clinical trial with 10,000 participants to prove it was safe and effective. You obviously cannot get a 10,000-person clinical trial for a disease that only affects 700 people globally.
So how do you get approval?
The FDA is now saying, if you understand the exact molecular mechanism of the broken gene and you have a targeted therapy that fixes that exact mechanism in the animal models, we will create a quicker, streamlined path to approval. But, and this is the crucial part for every parent listening, that rapid pathway requires massive, undeniable amounts of natural history data. The FDA needs to know exactly what the untreated disease looks like to prove that the new drug actually changed the outcome.
I see. So when parents are exhausted at midnight, filling out those endless surveys for the Global Patient Registry, logging every single seizure, or taking their terrified child to get a skin biopsy for the biobank, they aren't just doing busy work. They aren't just filling out academic paperwork. They're literally building the structural foundation the FDA requires to approve a cure.
Exactly. The parents filling out those forms are actively fueling the pipeline. They are the primary investors in this biotech startup. The leap from diagnosis to targeted gene-based treatment is no longer science fiction. It is a concrete, globally executed roadmap built on the backs of parent advocates.
Which brings us to the end of our deep dive today. Let's recap this incredible journey of building your A-team. You start with the geneticist, the forensic architect who decodes the broken blueprint and tells you exactly what kind of typo you're dealing with. Then the NICU team steps in, fighting the immediate physiological fires, the central apnea, the hypotonia, the feeding crises to stabilize the child and keep them breathing. As they grow, the neurologists and therapists become your core operators, managing the complex epilepsy and meticulously unlocking the child's potential to communicate through AEC. Then, the extra neurological specialists, the orthopedists, endocrinologists, and eye doctors maintain the integrity of the body systems, protecting bones from fracturing and vision from failing. And finally, the anesthesiologist acts as the ultimate gatekeeper of safety when surgical intervention is required.
It is a massive, incredibly complex team. But when you understand the underlying why behind each medical role, the biology driving the symptoms, you move from being a passive observer overwhelmed by jargon to the informed, empowered CEO of your child's care.
But before we sign off, there is one final, deeply provocative piece of science buried in our sources that we have to share. Something for you to mull over. We talked about how ultra-rare PURA syndrome is, roughly 700 confirmed people out of 8 billion on the planet. But the science indicates that the pure alpha protein itself might hold the key to diseases that affect millions.
Yes, recent biochemical analysis has highlighted something truly extraordinary. We know that pure alpha protein binds to RNA to transport instructions in the brain. Researchers have discovered that the pure alpha protein physically interacts with expanded, abnormal genetic repeats in a completely different gene called C9orf72.
And what does a mutation in C9orf72 cause when it goes wrong in the general population?
It is the single most common genetic cause of amyotrophic lateral sclerosis, ALS, also known as Lou Gehrig's disease, and frontotemporal dementia. Furthermore, researchers found that pure alpha also physically interacts with abnormal CGG repeats in the FMR1 gene, which is the gene responsible for Fragile X syndrome, the most common inherited cause of intellectual disability in autism.
Wait, so if researchers can figure out exactly how the pure alpha protein works, how it transports these messages, by studying the biology of children with PURA syndrome, they might unlock the mechanics of ALS, dementia, and Fragile X.
That is the profound implication of the current research. The intensive study of this ultra-rare pediatric condition may provide the broader insights required to unravel the mechanisms of some of the world's most devastating widespread neurodegenerative diseases. Existing evidence even suggests that pure might act as a critical neuroprotective factor in these conditions. By understanding how to boost pure alpha, we might find a way to slow down ALS.
So, to all the parents, carers, and family members listening, your child is not just fighting an isolated, rare battle. The precise medical data their lives provide, the biobanks you contribute to, the research your foundation funds, it might be the very key that unlocks the cure for millions of people around the world suffering from dementia or ALS. You didn't ask to be the CEO of this startup, and there was certainly no orientation manual when you started. You were handed a broken blueprint in a crowded room full of specialists. But look at the architecture you are building. You are keeping your child safe, and you are pushing science forward. Step into your next medical appointment with confidence. Know exactly why every single doctor is in the room, and keep advocating for your incredible child. Thank you for joining us on this deep dive.